Hey guys, I'm Chaston,
I'm Jessica.
and this is our rehab project for the ACL. All right, to start off with some subjective information, our patient's name is Michael Scott. He's a 30-year-old high school baseball coach who tore his ACL while playing a pickup basketball game on March 25th, 2017. He reports that he heard a pop after he went up for a rebound and landed on his knee awkwardly. He reports that he has pretty bad swelling and his pain level is at a 6 out of 10. And he notes that whenever he's trying to stand or walk or put any weight on his right knee, it tends to be really unstable. He does have a previous history of knee injury. It happened in September 1995 whenever he was playing basketball again and ruptured a bursa in his knee. Okay, now a little bit on the ACL. It is a ligament that originates from the medial and anterior aspect of the tibial plateau and runs superiorly, laterally, and posteriorly toward its insertion on the lateral femoral condyle. The purpose that the ACL serves is to prevent anterior translation of the tibia on the femur. And the physiology of the ACL. The ACL is composed of the anterior medial and posterior lateral bundles. These bundles provide around 85% of the total restraining force of anterior translation. It also prevents excessive tibial, medial, and lateral rotation, as well as varus and valgus stresses. Together with the PCL, the ACL guides the instantaneous center of rotation of the knee, therefore controlling joint kinematics. Now, the mechanism of injury, how most ACL injuries occur is when the foot is planted and there's a valgus load on the knee in combination with internal or external rotation of the tibia, as you can see here in this picture.
Okay, so for the non-operative intervention, some goals we would look at would be the patient would increase right knee active range of motion within normal limits, which would be between 135 and 145 degrees, and then extension between 0 and -10 degrees for the first couple weeks. And then another short-term goal would be the patient should be able to ambulate full weight bearing without pain next couple of weeks after that. And then for a long-term goal, patient will return to baseball practice and games with no pain within the next couple of months. So the plan for a non-operative intervention would be for patients presenting with little instability and almost full strength in the injured knee, an isolated ACL tear, so no other meniscus or any other injury there. And then non-operative treatment may be the option to start with for those people. The objective would be to regain full mobility, stability, and strength of that injured knee. And after the inflammatory phase is ended, which is probably when we'd be seeing those patients anyway, more aggressive strengthening techniques would be for the surrounding tissues would need to be implemented. And then so phase 2 of rehab, we would incorporate things like weighted squats, wall sits, weighted step-ups and downs, and knee extensions with the green or blue TherBand. So now I'm going to perform a wall sit. What we would do is tell the patient to stand against the wall with their legs their feet shoulder width apart, and then back flat against the wall, and then sit like they're going to sit in a chair as far down as they can go, really. And then to hold that for 30 seconds or so, and then they can stand up. And so for phase 3, exercises would include one-legged deadlift, back board balancing with dumbbells, short arc quad sets, box jumps with weights, and rotational step-ups with weights. I'm going to demonstrate a rotational step-up. I'd have weights, so like dumbbells or something. They would stand facing forwards and then step up into the chair or the box with their foot rotated completely 90 degrees from where it was. So like this. Up and then step down, and repeat this several times. And then for phase 4, exercises would include zigzag cone jumps, lateral slides on a slide board, hamstring curls, long arc quad sets, jump squats, and a 10-point suicide drill performed in under a minute. So I'm going to demonstrate the zigzag cone jumps. We just have cones on the floor, and we'd instruct them to jump in kind of a diagonal pattern. So jump forwards, jump diagonal, and then diagonal again. And that's it.
Alright, and if we were wanting to go the operative way of the intervention, the rehab goals would be as follows. There would be 2 short-term goals. First one of which the patient would ambulate full weight bearing on the right side with no assisted device by April 15th, 2017. And the second short-term goal would be to increase the patient's active range of motion in the knee to at least 125 degrees by April 8th, 2017. And the long-term goal for this patient would be to return back to sport-specific activities with no pain by July 25th, 2017. And now with patients with multi-ligamentous injuries, in conjunction with complete ACL tears and ruptures, would require the operative route of intervention. And in Michael's case, this is the route that's going to be implemented. So for phase 1, which is the inflammatory phase, it would consist of pain and edema management. Mainly modalities would be used in this phase, and 2 that I would personally pick would be cryotherapy of any kind, and to reduce the swelling and pain, and electrical stimulation on the quads to prevent further atrophy. And along with any upper extremity or lower extremity injury, it's always wise to follow the RICE protocol, which is rest, ice, compression, and elevation. And on to phase 2. The phase 2, which is mainly focuses on range of motion restoration, flexibility, and mobility. Exercises for this phase would include a 4-way straight leg raise, gravity-assisted wall slides in the extension and heel slides, bilateral short arc quad sets, and chair scoots. And I'm going to demonstrate what a chair scoot is. So you would instruct your patient to grab a seat in a chair and sit down, place their legs hip width apart in front of them, and tell them to scoot forward. And you'd want to do that for about 10 to 15 times per set. And on to phase 3, which mainly focuses on increasing the strength, endurance, control of the knee, improving proprioception, balance, and stability. Exercises for this phase would include prone knee extension, hamstring curls, seated leg press, terminal knee extensions with TherAband, long arc quad sets, and lunges. And I'm going to demonstrate how to do a lunge. You pretty much instruct your patient to take one knee, flex out like this, but don't let the other knee touch the ground, and then come back up and repeat with the other leg. And it's important that the knee doesn't touch the ground to prevent further injury. And on to phase 4, which focuses on the full restoration of strength, control, and endurance of the knee, along with surrounding musculature to be equal bilaterally and returning to a previous level of functioning. Exercises for this phase would include plyometric box jumps, zigzag cone drills, ladder drills, rotational step-ups, lateral slides on a horizontal slide platform, and lunge jumps. And I'm going to demonstrate just the basic run-of-the-mill plyo box jump, where there would be a box in front of the patient. You would stand in front of the box, and you would instruct them to jump and land softly on it.
And then, so the major differences in the operative versus the non-operative ACL rehabilitation would consist of the following. So the conservative approach focuses more on stability, range of motion, and flexibility without surgical intervention. The surgical approach tends to include exercises tailored toward the inflammatory phase at the beginning of rehab versus the beginning with strengthening rehab. And then post-operative rehab patients are more inclined to adhere to the program because generally they're a more active population. So that's kind of why we chose the surgical route for Michael. And these are our references.